Hello, and thank you very much for joining our Burn Management 101, specific for emergency department healthcare professionals, in collaboration with the Canadian Association of Emergency Physicians. I'm Ashley Hudson. I am a nurse specializing in wound ostomy and continence, working with Smith and Nephew with our clinical strategy team. I'm also joined by my colleague, Billi Payne, medical education manager for Burn. And I'm very excited that we have the opportunity for Dr. Sarvesh Logzetti, who is the director of the Manitoba Firefighters Burn Unit Health Sciences Center. He is also the chair of the Canadian Burn Network and a founding member and the president of the Canadian Burn Association. So today's learning objectives is that by the end of today's education session, that you will have the opportunity to recognize not only the impact of burns, but the importance of a multidisciplinary approach, which patients that come into your emergency department you want to refer into a burn center. Review the three phases of burn care. In the emergency department, you'll mostly triage, emergent, resuscitative, and acute burns, but knowing that what happens at the beginning of the burn survivor's journey is also very important for their ongoing rehabilitation. We will be reviewing the assessment of burn depth, as well as implementing an algorithmic approach to the management of adult burn wounds and walking through some tips and tricks for applying burn dressings, as well as where to reach out for additional resources. For the purposes of today's education session, we will be focusing primarily on burn wound management, although there are a variety of different aspects of burn care, including fluid resuscitation. As well, we will be focusing today on the adult burn patient. So the majority of burn injuries in Canada are going to be triaged and treated through your emergency departments. Some of these burn patients will be transferred to a burn center. Others can be managed in the hospital. Many smaller burns may be treated in the emergency department as outpatients or even outpatient clinics, or even home health and in the community. Burn injuries can be costly to the healthcare system, but also, to the burn survivor, who may experience decreased productivity due to disabilities related to their burn injury. So, Billi, can you let everyone know not only the importance of burns in a multidisciplinary approach, but who is on the team?
Sure. Thank you, Ashley. So emergency services is where it starts. And some people automatically think of paramedics, but civilians can be the first on the scene. And then, of course, our emergency personnel, which includes firefighters, policemen, and EMTs. And they are responsible for first removing the patient from danger, stabilizing the patient, and then transporting it. Of course, our physicians are in charge of patient care and surgical debridement, grafting, and their ongoing directives. Our mid-level support our physicians. These are nurse practitioners and our physician's assistants that are alongside and aligned with the physicians in the OR, as well as directing care on the floors in the clinics. The nursing staff is responsible for the care of the day-to-day of the patient, the dressing changes, being the administrator of the prescribed medications, and doing the activities of daily living alongside the physical and occupational therapists. And these also include speech therapy. So if we have patients that have been vented for a long time or were inhalation burns, all of these therapists are going to have a major role to play. Our dietitians are very important. We know that burns take a lot of calories, and it's very difficult for patients to heal without a balance of nutrients and the extra support they need there. Social workers and chaplains, psychologists are there for ongoing support. They stay with the patients and the families even after discharge and work with helping them integrate back into society. The case managers are there to help them to get there for ongoing care and for where they're going to be. So all of these are vital to the success of treatment and the patient care. And in an effort to guide this approach, we have some organizations that give us some guidelines. Miss Ashley, if you don't mind, go ahead and put that back up there. This is the American Burn Association and the Canadian Burn Association. Both work in not setting out protocols, but setting out guidelines for the care of patients. And they use best practice and research that come from our burn professionals. Burns are very unique in both pathophysiology and treatment. Thus, referrals to burn centers is very important. And there are guidelines from the ABA and the Canadian Burn Association when patients should be transferred to burns. I think I have a slide here telling us about that criteria, what we consider. Ashley, if you don't mind going on to the next one. Our type, depth, extent, and extenuating circumstances. And Ashley, I think you have a QR code here that you wanted to speak to.
Yes, so there is a QR code on the right-hand side of the screen. You can take your phone with your camera, similar to those fancy, new menus at restaurants. And what this QR code will bring you to is to the Canadian Burn Association's resource website. And there you will find all of the varying burn centers and their contact info across Canada, because I know in speaking both with Dr. Logzetti and other members of the Canadian Burn Association that they are there as a resource to speak to the emergency department physicians when you're unsure of whether or not to transfer a burn. Also, any other questions about the care, they are there to help and support you.
Fantastic. Thanks, Ashley. So among the criteria, we know types would include such as inhalation, electrocution. Depth is, what we're looking at in full thickness, also the TBSA, and then if they have any comorbidities. So let's dive into the treatment of burn patients themselves and the criteria we follow. The burn care can be categorized into 3 areas. First being the emergent resuscitative phase, then the acute intermediate phase, and then finally the rehabilitation phase. Let's discuss the phases in detail, starting with that emergent phase. So when we look at the emergent phase, we're looking at the first 72 hours. So this is the first 3 days post-injury. And in burn care, we talk about post-injury day or post-burn day. And then after surgery, we talk about post-op day. So here we're talking about, aside from surgery, the first 72 hours. And this is where we're applying our ABCs of health, of all trauma. We're checking for airway management and breathing. We're assessing circulation, and we're monitoring adequate perfusion. We're making sure we're not dealing with compartment syndrome. We're treating any life-threatening injuries. So if there was any penetrating wounds, maybe they jumped out of a 3rd story of a building and landed wrong. So there are other traumas that can be involved with the burn that need to be dealt with and stabilized. Fluid resuscitation is extremely important. Our fluids are shifting quite a bit in burns, especially when we have them of higher TSA and deeper depth. So that's our next thing we're assessing is type. When we look at these 3 things, this is how we're going to describe our burn and how we're going to treat it. Let's start with the type of burn injury. So types of burn injuries are thermal burns, chemical burns, electrical burns, smoke and inhalation injuries, and radiation burns or exposure. And any of our viewers that see that top one and ride motorcycles, I bet they recognize that first thermal burn. I happen to have one of those on my leg, not nearly that bad, thank goodness. We look at inhalation burns, and we know we're going to be intubating this patient. So there's many considerations when we deal with burns and the type. Go ahead, Ashley, we'll move on. So the next thing we want to know is the extent of the burn. So when we look at the extent of the burn, we are going to use different methods to measure that. 3 that you may be familiar with, most of us are, is the rule of 9s, the Palmer method, and the London-Browder. Let's move on and take a look at each one of these separately. So the rule of 9 is generally what most people understand as measurement for burns. And you will have our emergency care people will use the rule of 9. Our ER people will use rule of 9. And it's a good way to get us a better idea of the extent of the burn by dividing the body surface up in 9% at a time. So it is a little bit different for children than it is for adults, as the heads are much larger in relation. But the rule of 9 is what you hear most often when people talk about burn TBSA. So the Palmer method, I call this the down and dirty. And what I might use this for is if you hold up your hand is 1% total body surface area of your for yourself. So it's relative to the person. And if I go down as a burn nurse to the ER and I clean the patient up a little bit and I need a quick number, I might use that Palmer method to get a good idea of the surface area. And then when we get them up to the burn unit, we're going to use a more in-depth method of totaling TBSA, and that is called the London-Browder. The London-Browder is more comprehensive because not only does it take in the surface area, but it takes in the depth. So you can divide it by partial thickness to full thickness, and we get a better idea. I think I have an example here on the next slide that shows a burn that I colored in how much was partial and how much was full. So we get a better idea of TBSA, the depth, and this is what the number that most often will be used for our fluid resuscitation, medication, and caloric intake. So just a little trivia. I'm not expecting an answer since we were recording this, but we often say there is a percentage of TBSA that correlates to a length of stay. I'll give you just a second while we switch the screen. So what we generally say is, aside from other trauma and comorbidities, 1% TBSA is equal to 1 day stay in the burn unit. So if somebody is a 14% TBSA, then we can average that they're going to be with us for about 14 days. This is not a hard and fast rule, but it's a general rule that we often use in the burn unit itself. Let's talk a little bit more about assessment and the final step, which is the depth of the injury. So I left this in here, and most of us may have seen this. This is Jackson's view, or Shoup's view of the depth of injury. This is showing the epidermis, dermis, hypodermis, and muscle. And it's a great indicator of what we refer to in burn as superficial, superficial partial thickness, deep partial thickness, and full thickness. When you get to full thickness, we're down past all those hair follicles into the fascia. So breaking each one of these down, and this is a fairly quick review. Superficial is what might be referred to as first degree. This involves only the outer surface of the epidermis, You're going to see pink, red skin, no blisters, dry, and delayed pain. This can heal on its own with very little intervention in 3 to 5 days with no scarring. And most of us who are love being at the beach have probably experienced this superficial first degree in a sunburn. Moving on to the second degree. So there are two that fall into the second degree. Superficial partial thickness is the first. This involves the epidermis and the upper 1/3 of the dermis. This will also have a pink red tone. It might be a brighter tone of pink or red. It still blanches with a nice rapid capillary refill, but there might be blisters, and these blisters may or may not be intact. Depending on that, we might have a moist surface and it might be weeping a little bit. There is extreme pain because we have not reached into those nerve endings. And so everything's fully intact and it's just a raw open wound. Typically, we have no scarring with this. We want to keep it clean and free of infection, and it can heal in about 7 to 14 days. The second half, or the second 2/3, I should say, of a second degree burn is deep partial thickness. This involves the epidermis all the way through to deep dermis. This can have different colors. It can be mixed red or waxy white in the areas that have lower perfusion. It is slow to blanch. It has a slow capillary refill. We have assaulted that deeper dermis where the hair follicles are. And we have probably broken blisters, a wet surface, and we're very susceptible to infection. Pain is minimal, not gone, but minimal due to the damage to the receptors, though it is still sensitive to pressure. And we know that at any burn of depth, it's never one depth because the surrounding areas may not be as deep. So it's not void of pain, but it is dull in sense. This can heal in 4 to 6 weeks with proper care. There is potential for scarring. Here we have a full thickness burn. This is what is considered 3rd and 4th degree. This patient that you see here was, I happen to know, an electrical burn. So this was, of course, multiple surgeries. This involved the epidermis, dermis, and underlying structures. You can have any color, and you can see that in our patient right here. We have red and white and black and charred areas. There is no blanching in the full thickness areas. We have thrombosed vessels. You might see the vessels showing black or dark blue through the skin. Poor to no distal circulation. This is where we're concerned about compartment syndrome. It can be dry and leathery, rigid. When you go to clean, if there's hair there, it easily wipes out or wipes away. There is quite a bit of pain because we have other things that are going on. We have surrounding tissue area. We might have sclerotic fasciotomies, and the extended healing time involves multiple surgeries and grafting. So let's talk about that sclerotomy and fasciotomy. This is about the compartment syndrome. When we have reached that full thickness and it is strangulating the perfusion, we are also having a lot of our fluid shift. It might call for an sclerotomy or a deeper fasciotomy. And that's what you see in these pictures here, where in that second picture, it's down to muscle. And this is where it has occluded blood perfusion all the way to the extremities. So it needed to be opened up and relieved so that we could have circulation and healing can take place. Ashley, I'm going to have you just go ahead and click through these. What you're seeing here is a quick snapshot of the 4 superficial, deep partial, and full thickness. And it's a nice little look at the depth of the burn on each, the wound color, vascularity, the surface appearance, the presence of pain, and the healing time. And it's a really good look at the difference between the 2 or between the 4 and especially when we're looking between the superficial partial and the deep partial. So we know that burns are not static. The dynamics of burns continue. Go ahead and click that, Ashley. And they can continue to what we call convert, because we get stuck in that inflammatory stage where we have no proliferation, we have no granulation, and you can continue to have tissue death up to 23 days. We also know in burn, if we can have closure or granulation started in less than 21 days, we have better outcomes when it comes to preventing scarring and full range of motion. Thanks, Ashley. So the zones of classification are important to us, and I'm going to skip from A to C and talk about zone of coagulation is what I call ground zero. That's the area that has received the most amount of damage. This is full tissue death and requires grafting, debridement and grafting. C is that outer ring. And this is the zone of hyperemia. Think about that sunburn. This is the area with the least amount of damage and has the ability to heal. Where we as burn clinicians spend a lot of time, a lot of effort, and a lot of money is in the zone of stasis. I call that the teeter-totter area. That zone of stasis, the area that can heal if properly cared for, kept free of infection, and get past that inflammatory stage, or it can convert, looking at the slide before where we have up to 23 days, we can have tissue damage. So that is the zone of stasis that we spend a lot of time in industry and in the hospital working to get the best outcomes for our patients and to prevent further tissue damage. This is a little quiz that I do, and we're going to go ahead and just put it all three up there on the slide so you can take a look of the three zones on this patient. We have the zone of coagulation there with A. That area is going to need to be debrided and grafted. The zone of hyperemia are the surrounding areas that we're going to have some healing. We want to keep it clean and free of infection. But we have that zone of stasis where we know we can see conversion. We can see it go deeper. It may need to go ahead and be completely debrided, but we want to protect it from infection and we keep it from getting worse. We want the best chance to spare as much tissue as possible. We can move on to the next one.
So now we're going to transition to talking about some of the barriers to burn healing. So of course, the first is to stabilize and assess the patient during that emergent and resuscitative phase. However, some of the priorities that continue as your interventions include pain management, minimization of the risk of infection, and that continued removal of burn and wound debris and any non-viable or any dead tissue in effort to minimize inflammation and to support healing. Traditionally, the intervention of debridement has been performed in two ways: early aggressive excisional debridement, which is aimed to remove the majority of non-viable tissue as quickly as possible in effort to limit further damage, or tissue preservation approach, in which treatment interventions aim to preserve salvageable tissue removal and post-injury complications such as scarring. So the tissue debridement, is, other than removing blisters and removing some of that dead debris within your centers, is more than often going to be done in the burn centers for those full thickness and deep partial thickness burn injuries. So we're going to get a little bit more into the acute or intermediate phase of burn wound management. And so the acute or intermediate phase of burn care follows the emergent resuscitative phase and begins 72 hours after the burn injury. During this phase, attention is directed towards continued assessment and maintenance of respiratory and circulatory status, fluid, electrolyte balance, GI function. Very important is that infection prevention and localized burn wound care, including pain management, as well as nutritional support, are priorities that are all set at this stage. So we're going to move into talking, about the importance of prevention of burn wound infection. Infection is a great concern for burn clinicians, in fact, and burn surgeons. Infections are one of the leading causes of mortality and morbidity in burn patients. Moreover, increased TBSA has shown to have an increased association with the risk of infection. Prevention is key as burn patients have lost their protective mechanisms from bacteria and toxins. Increased bacterial contaminants can impede the burn wound healing by promoting excessive inflammation and damaging the tissue. A major secondary source of pathogenic microbes is the environment. Infection control has a major role of burn team, or in your case, the emergency department team, in providing appropriate burn wound care. Caps, gowns, masks, and gloves are worn while caring for the patient with open burn wounds, and clean technique is used when caring directly for burn wounds. Antimicrobial dressings with a sufficient and sustained level of antimicrobial agent can provide a barrier to help to protect and manage the bacteria from the wound, specifically by killing the organisms. So, Dr. Logzetti, why is infection prevention key when starting in the emergency, and it starts in the emergency department?
When you examine a burn wound, as you've already outlined, you have a burden of necrotic tissue, and it's similar to taking a thin slice of steak and tying it to your limb, a leg, or an arm, and hoping that it doesn't get infected. If the heat was enough to damage the skin and kill the skin, it's enough to damage the bacteria on it. So you're starting from a clean wound, not necessarily sterile, but clean, and it's our responsibility to stop it from becoming infected.
Thank you. So as we've discussed, different burn injuries can have different pain management requirements. What is, some of the most up-to-date information, Dr. Logzetti, and different types of pain that burn survivors can have?
I think that overall, we've been trying to move away from a heavy narcotic-based pain management regimen to using adjuncts that are non-narcotic based. I think that they should be maxed out first. And there's when we approach pain, as you've outlined in the slide here, it's a background pain versus procedural pain. As you all know, that a burn by itself causes a fair amount of pain, so we need to make sure that we have some long-acting medication that may or may not involve narcotics, depending on the size and extent of burn. We should start off with making sure that Tylenol and NSAIDs are used to the best of our ability, understanding that there are contraindications to that in individuals with ulcers or liver disease. And then and when you have procedural pain, we need to add in some short-acting medications, potentially narcotics such as fentanyl may be useful, and understanding that procedural pain isn't just for dressing changes, but also for the physiotherapy and occupational therapy and rehabilitation activities that are present as well. And it's really important to differentiate between anxiety that's associated with the dressing changes and pain itself, and not rely on analgesic medication to address anxiety. There's a lot of evidence that mindfulness techniques and breathing techniques and can help decrease the amount of pain and anxiety that individuals experience during burn dressings. So we use those fairly aggressively in our unit.
Excellent. And Also, during the procedure as well, from a nursing perspective, of course, it's, always really important to prepare the supplies first, to have everything ready to go. And why would that be, Dr. Logzetti, to make sure that you have everything ready and the room is kept warm?
I think you're hitting on some really important issues there. Number one is by being prepared and showing the patient and the burn survivor that you are prepared, you're making them feel confident in your abilities to do the procedure that you have to do. Number two is that the exposure of the wound to the air is what hurts. If you have it covered, the pain is decreased. And by minimizing the amount of time that it's exposed to air, you minimize the pain and anxiety that the burn survivor is experiencing. And then number three is that by decreasing the amount of exposure, you're decreasing the risk of contamination that can occur. Because every time we expose the burn wound to the atmosphere, you're increasing the potential that it's going to rub against something, or something is going to contaminate the wound and start the transmission of bacteria into that. I think that some of the things, the adjuncts that you've outlined on this slide, things like the use of ketamine and propofol, are useful while you're in emergency or on the ward. I think it's challenging to do those at home, needless to say, but there are other ways of administering things like oral fentanyl, sublingual, and or even sublingual ketamine in some situations can help people as well.
Excellent. And would you agree that most of the burn survivors that would be requiring, ongoing ketamine and propofol pain management, that in reality, those are patients that are more often going to be transferred to the burn center?
100%. I think that if you're requiring that level of analgesic and or anesthetic, then you really do need to be in a specialized center. The other medication that has recently started to come back into the vogue from the burn world is use of potentially nitrous oxide as an adjunct. Having said that, that should be done with appropriate consultation with your local anesthesia team, because it does need to be scavenged appropriately and does need to be administered and monitored properly.
Excellent, thank you. So we'll now transition into digging into burn wound management, and what some of the questions that had come up in my previous role in educating within emergency departments on burn wound management. Always remember, especially at the scene when that survivor arrives in your emergency department, that your first priority is really the ABCDs, DEs. So your airway, breathing, circulation, disability, exposure, and then, of course, at the scene, that secondary survey to ensure that you're not putting yourself in danger. Another question that has been frequently asked is, to cool or not to cool the burn injury, what to transfer the patient with. Is it appropriate to put on saline soap gauze to transfer a burn patient to a burn center? So we're going to talk about all of those frequently asked questions in just a moment. Also, there's that decision on when to transfer to the burn center. And so Billi did a great job at identifying the burn center referral criteria at the beginning of today's presentation. We're going to tie that into an emergency department algorithm here in just a moment. And then also, if that survivor is not going to be transferred to the burn center, do they need to be kept in the acute care hospital, or can they manage at home in the community, returning to either the emergency department or outpatient clinics? So this resource will be available in a full page over on the Smith and Nephew resource portion of your CAPE portal. Starting at looking at what is the type of burn. So if it's a chemical burn, then that is automatically a burn injury that requires transfer to the burn center. However, in the meantime, whether it's at the scene or in your emergency department, it is really important to protect yourself from the chemical with gloves, gown, eye protection, and also before flushing off the chemicals to dust off any powder copiously with room temperature or cool water until the patient experiences that decreased pain and stinging. And then the burn wound is going to be evaluated at the treating burn center. So if it's not a chemical burn, then looking at, is it a tar or asphalt burn? If yes, then again, this is a burn type that would require transporting the patient to the burn center and connecting with the burn center for that referral. You can also cool the molten material until it's fully cooled to help stop that burning process. You can also cover with a petrolatum based product, and you don't need to worry about in the emergency department removing the tar or asphalt. That is going to be done at when the patient arrives at the treating burn center. So if it's not a chemical burn, it's not a tar asphalt burn, we are not talking about radiation burns for purposes of today's webinar education session, then more than likely it's going to be a thermal burn. Thermal burns are one of the most frequent burn injuries or types. So this is again where you're going to be checking, for guidance from the burn center referral criteria. And this is also where it's important to look at what is that total body surface area. Is it less than 5% TBSA, or is it greater than 5% TBSA? So if it's less than 5% TBSA, then this is where you can stop the burning process by flushing burns carefully with room temperature water or with saline. Local cooling of the burn for these smaller burns can also be done utilizing a saline soaked gauze, but it's really important to be maintaining the patient's internal temperature to prevent hypothermia. And then the other thing to consider is, will cooling of the burn injury, will it delay care and transfer to an acute care hospital? So if it's not going to delay transfer, then it is completely appropriate to flush with even tap water for up to 30 minutes. Now, if the TBSA is greater than 5%, then you're going to also be looking, at the, does the patient meet the burn center referral criteria? And the secondary question to ask is rapid transfer possible? Dr. Logzetti, when we've spoken previously about this, is there a definition for rapid transfer?
There isn't a clear definition that's based on any true evidence or science, but at our institution, we use a threshold of 4 hours because most of our regions we can reach within 4 hours. And we say that if you're going to send somebody in that has a transport time of less than 4 hours, then just put some dry dressing on, some dry towels like the green towels or something along those lines, versus putting a burn survivor through a dressing that we're going to just cut off as soon as they come to our institution so we can review the wounds. If it's more than 4 hours, then I think that the risk of the wound becoming infected or contaminated outweighs the risk of the dressing change. So we say, please put a dressing on, and then we'll take that off when they get to ours. Quite often that's, delays related to weather, blizzards, things like that in our environment.
Excellent. Thank you for defining that. And I know we also spoke that depending on where you are in Canada, it could vary from that 4 hours. In speaking with, for example, Thunder Bay Hospital, some of their patients, it's going to take them days to get to a burn center. So again, this is, great for always, not being afraid to reach out to your burn center when you have questions. I have been in situations in the emergency department where, deciding what to put on a burn injury of a patient that's getting transferred rapidly out of that emergency department has been quite stressful for emergency department staff. And really, it's all about, stabilizing that patient, keeping them warm, as Dr. Logzetti said, and just covering with a clean, dry sheet or dressing. That wound management piece really comes, into play when the patient themselves meets the burn center referral criteria, and the transport will be delayed, or they're going to actually be treated within your local emergency department, hospital, or community. And that is, where then you will take some of the steps that you see on the screen here. Of course, following your facility's protocol for wound cleansing. As we spoke about, having all of those supplies ready and prepared, keeping the room warm. And it's really important to also gently debride any blisters that are greater than 2 centimeters in size, so that the antimicrobial dressing has the ability to reach that burn injury surface, but also so that you are removing any dead tissue. Your next step would be to apply a topical antimicrobial dressing, such as Acticoat Flex 3. There is also an Acticoat Flex 7, but typically it's the Acticoat Flex 3 that is utilized most within burn injuries. And it's also very important to continue to assess the burn and provide, care per your facility's protocol or any guidance from the burn center that you may be collaborating with. So some of the, reasons why antimicrobials are utilized within deep burns is really to minimize that bacterial colonization and decrease the risk of infection. Topical management of, your superficial partial thickness and deeper partial thickness burns require a variety of different formats of antimicrobial dressings to promote that wound environment for healing, but also to decrease any of those environmental factors that can cause pain. What is great about Acticoat Flex is its broad spectrum. So what that means is effective against a variety of different pathogens, including MRSA, VRE, and Pseudomonas. And if you're using Acticoat Flex 3, it can be left in place for 3 days, versus Acticoat Flex 7 can be left in place for 7 days. However, from my past experience, I really found that it can be quite challenging to keep dressing moist for 7 days. I'm curious, Dr. Logzetti, how often do you typically change your Acticoat dressings in your facility?
We tend to change our acute care Acticoat dressings 3 times a week, Monday, Wednesday, and Friday. Partly because while recognizing that we could change them twice a week, it's easier on our scheduling to know when all of our dressings are. And our other standard dressing is polysporin or triple antibiotic ointment and adaptic non-adherent gauze. And we do that Monday, Wednesday, and Friday. And so this way the nursing can schedule and have appropriate resources on the days, as opposed to a random collection of days from that. Just as an aside, we place our nanocrystalline silver on as a dry dressing and allow the wound itself to moisturize it or moisten it, as opposed to trying to moisten it from the outside.
That's a great tip. And one of the biggest questions too that I do get asked is, do you need to pre-moisten or activate Acticoat? So thank you for clarifying that. And why is Acticoat utilized in antimicrobial dressing in burn injuries, Dr. Logzetti?
For us, I can, because we've taken a look at the literature and identified that it is one of the only silver dressings that actually has an in vivo antimicrobial effect. So that's why we use a nanocrystalline silver.
Excellent. Thank you. So back to, talking about how to be prepared, and, the products that you see on the screen are Smith and Nephew's products that you potentially may want to have as a burn dressing kit, or have available somewhere within your emergency department, so that when a burn survivor arrives, you're ready. So some of these dressings and resources would include, having the quick reference guides, and, potentially, algorithms, application guides on how to actually change the dressing. For your superficial partial thickness burn injuries, or burn injuries that may be on that healing plateau, Gelinet, which you see on the screen here on your left. This is a paraffin based open weave low adherent contact layer. It can also be utilized with a topical antibiotic. We've talked a little bit about Acticoat Flex, which is the nanocrystalline silver technology. One of the things that I always do like to also share within the education sessions is that it is a polyester mesh. So as Dr. Logzetti mentioned, if the burn injury has lots of exudate or is a moist burn injury, then you simply can apply it either way, dry. But one of the other products that is typically used with Acticoat Flex, as the exudate decreases and as that burn injury moves on to healing, or even just that, especially when it gets that drier burn injury, is intrasite gel, which is sterile water hydrogel. One of the things that we don't recommend with Acticoat Flex is to moisten it with normal saline. Moistening it with normal saline, you would have the chloride ions that can actually bind with the Acticoat and make less silver available at the burn injury. Now, if you only had normal saline to cleanse with, that's fine, but it's really, you don't want to be, moistening the Acticoat or applying moistened gauze with saline. You're typically using sterile water. And then to cover the burn injuries, you can use a variety of different products. For larger surface areas, there is large Alleven non-adhesive dressing, which is a foam dressing and would be absorptive. Simply secure it with some cling. For some of the smaller burn injuries, and you could use a silicone bordered dressing, such as Alleven Gentle Border. Or for some of the very large burn injuries, or exudative burn injuries, you could actually use something called Exudry, which is a great product because it actually has an anti-shear layer to help to prevent shearing on that delicate area. Some centers also use something as simple as a cover dressing as burn gauze and cling. And then especially for your hand burns, that is also where you may find it useful to have something that's called burn netting, basically to hold everything together. Now, can I ask you, Billi, if you have a hand burn injury, and I think I'm getting a little bit ahead of myself, but this is where I get really excited, is about how to apply the dressings. If you did have a hand injury, burn injury, would you wrap it all together like a club, or would you want to wrap each digit separately?
That is a great question. And when burns are open, the skin wants to heal and it wants to heal together. We also want to maintain full range of motion. So we would wrap them individually, and I always would wrap them at full range. So this is a good time for occupational therapy to do their assessment, because they can hold the hand while you wrap individual. And then, after you have something that keeps the skin separated and full extension, then you can put the netting or whatever you want on it. But for me, I loved to do an Acticoat Flex wrap around each individual finger, and then the gauze, and it did a beautiful job. That's a very good question.
And is that something that you've seen in your hospital, Dr. Logzetti, also wanting to preserve that range of motion?
100%. I think that, one of the worst things that you can see is somebody who comes in whose hand has been either wrapped as a mitten or, like a fist, and then you're trying to get them to move afterwards and they can't because now it's all scarred down and they're stiff because they haven't moved it appropriately. So we really do want to try and encourage that motion. And, we talk about splinting, but splinting really needs to be done only as a last resort. And we really want people to be moving as much as they can and be engaged in their therapy.
Excellent. So we've talked about, some application tips and tricks, the importance of maintaining that range of motion. One of the things to be, watch out for is to continuously to assess that burn injury. And so if the patient comes back to your emergency department and let's say the Acticoat dressing has stuck to that burn injury, first off, you don't want to rip it off. You can actually soak it with sterile water, or at this point, because you're not moistening for wound management, normal saline. And if you notice with the Acticoat Flex, there is actually a lateral stretch. So if you can find that, then you can actually easily break that seal of the Acticoat from the burn injury. If you see that, or if you notice that there's less, the burn exudate is decreasing, then this is definitely where you want to apply intrasite, a hydrogel, such as intrasite gel.
I think that another technique that you can use to decrease the adherence between the nanocrystalline dressing and the wound itself is that you can put soap on it. So we do chlorhexidine soap and it breaks it because the current nanocrystalline dressing is very hydrophobic. So trying to wet it doesn't always work. Some of the other things that you can do is you can soak the dressing itself before you remove it for 5 minutes or so. There's no need to soak it for longer than 5 minutes. We've demonstrated that in an animal model. And it will help sort of keep the contact to break that initial hydrophobic or inability to wet the nanocrystalline dressing.
Those are some excellent tips. Thank you for sharing them, Dr. Logzetti. And also, speaking about how this is a hydrophobic dressing, I find that, one of the tips is you can apply, as in this photo, the intrasite gel down first to the burn wound. However, the importance of covering with a cover dressing that's going to maintain moisture within that wound instead of dry cover dressing that's going to evaporate. I like to also share a little, it's not anything technical or branded, but something called smudging. And so going back to Dr. Logzetti's point about utilizing your hydrogel, of course you would have on sterile gloves if you were touching the dressing like I am here on camera. But then you actually, for this one 10 by 10 piece of Acticoat, you do use almost this full container. And speaking of that hydrophobic, you do have to massage it into the Acticoat or
make a mud pie.
Make a mud pie. Or exactly. Before applying it to the burn wound. And then of course, always making sure that if you have minimal exudate, to cover with that appropriate cover dressing. Of course, that importance of assessment is key because you don't want to add too much moisture. You can see on this screen here that this is an example of maceration. So when you have too much moisture, this is where it can lead to maceration. And the last topic for discussion is silver staining. And so, of course, utilizing a nanocrystalline silver that is actually releasing the silver to that burn injury or even onto the skin, especially if you're overlapping on a scattered burn injury, can cause staining. This is normal. Patients can for sure be concerned that this is a permanent color discoloration. It is not, you do not need to scrub this off. It will actually naturally resolve as your epithelial layer reepithelializes over a maximum of up to 21 days. Anything else to add, Dr. Loxetti?
I was just going to say, you can also see on this picture that one of the things you can see with the Acticoat is a dry pseudomembrane or pseudo-eschar that forms. It's kind of like a layer that's just the protein coagulation that occurs with the silver release, with the nanocrystalline silver. Sorry, I think I'd said a trade name there and I didn't mean to. I know this is supported by Smith & Nephew, but I'm trying to stay neutral.
Yes.
The pseudomembrane is not a sign of infection. It's not, bad. It actually is a sign that the silver is probably preventing the bacterial invasion of the eschar itself. So it will slowly lift with time.
Thanks for pointing that out. I've heard others also talk about it, that fight at the injury level between the silver and the bacteria. But I have seen nurses, very concerned that it's actually a pus when it is a moisture pseudomembrane. So thank you so much for bringing that up. So last but not least, we shared, some great resources at the beginning of this presentation. But here on the slide is a variety of different Canadian publications for burn care and treatment, prevention, management of burn injuries in Canada. Of course, I think for us as Canadians, the Canadian Burn Association is definitely our robust resource. And also there is resources through the American Burn Association, the International Burn Injury Society. For patients, actually, there are some great resources for patients and their family members or friends through the Phoenix Society. I know the Canadian Burn Association, and maybe you want to share this, Dr. Loxetti, has their annual conference bi-yearly now, and there's a lot of great education offerings there.
Thanks very much for that plug. Yeah, the meeting is hopefully going to be in 2024, and the plan is to be in the Niagara region. We may have one in 2023, but we're thinking about every second year from now. And we will hold an advanced burn life support course at that time as well for those of you who are interested.
Excellent. Thank you. So really to summarize today's education session, dealing with the impact of burns, it is really a team approach. There are 3 different phases of burn care. And what starts out within that emergent and acute phases really can impact the ongoing rehabilitation. Burns should be assessed based on their type, the extent, and the depth. And remember, really, as Billi was mentioning, that zone of stasis is really, what we're trying to preserve, so that that burn injury does not actually worsen. So thank you again for taking the time out of your busy day to attend this recorded education session. If you do have any questions, do not hesitate to reach out to any of us at Smith & Nephew, or even to your local burn centers. Thank you so much, Dr. Loxetti and Billi, for taking the time out to co-present and provide education to improve outcomes across Canada in burn survivors.
Thank you very much. Thank you, everyone.
Thanks, everyone.
For attending.